Yes, sir. It is streaming over there. We can
Okay,
start.
we can start, right?
Yeah.
Okay. So netcast is ready, right?
Yes, sir. Please go ahead.
The screen is visible.
Yes.
So a very good evening to all respected doctors, our distinguished panel of the senior experts and the specialists, my dear colleagues, ladies and gentlemen. At the outset, me Sandeep Mitra, on behalf of Nobilis Mankind Specialty, take this immense pleasure and the honor in extending a very warm welcome to this evening symposium entitled Tipping the Scales, SGLT2 Inhibitions in Cardio-renal-metabolic Spectrum. And at the outset, we are extremely thankful to each one of you for accepting our invitations and making this event possible. Dear doctor, as you know, that Nobilis Mankind Specialties is a super specialty diabetes and cardiometabolic care team to serve the life of millions of people suffering with diabetes and the metabolic diseases across the country with the most affordable and quality healthcare products and the services. One of the very integral part of our strategic intent in Nobilis Mankind Specialty has been to remain the forefront in the knowledge sharing, and where we have made an exclusive strategic partnerships with some of the eminent national and international congresses of the global repute, and also to remain forefront in the patient awareness and educations in the chronic disease through the various digital healthcare solutions like One Life and the Prana Life Course. And it was never been possible without your relentless support, your encouragement and inspirations. Thank you so much towards that. Now, let me take this honor and the opportunity in welcoming and our very distinguished experts and the specialist in endocrinology and metabolics, Professor Dr. Vipin Kumar Sethi. Professor Dr. Vipin Kumar Sethi, who doesn't need any introductions to this audience, he is a very distinguished expert and senior consultant endocrinologist at CARE Super Specialty Hospital and Transplant Center in Hyderabad. Thank you very much, sir, for joining and accepting our invitations. And we are having Professor Dr. Ganpati Bantwal, who is a professor, Department of Endocrinology, St. John's Medical College and Hospital, Bangalore. Thank you so much, sir, for joining and accepting our invitations. With this brief note, this is our program schedule for the evening. Now, with your kind permissions, let me start by a very brief discussions on the relatively newer concepts in the Indian drug space. So for the chronic therapies are being concerned, and that is drug master file. And dear doctor, drug master files, we recently introduced with the dapagliflozin in Indian market segment, which is going to be having a newer breakthrough. And let's have a quick snapshot and the bird's eye view about the discussions of some of the clinical implications of the drug master file. So, as we all know, from the clinical perspective, the drug master file is basically, it's a regulatory submission process to the Food and Drug Administrations or FDA about the manufacturing, processing, packaging, and the storing of one or more of the human drugs. In fact, drug master file, it contains a very comprehensive, factual, and the complete information pertaining on the drug product chemistry, its stability, purity, impurity profile, packaging, and the current good manufacturing practices status of the human drug product. Now, basically, what does it bring on the table? So drug master file, primarily, it communicates the quality, safety profile, and efficacy of the drug that is internationally being accepted. And towards that, manufacturing facilities or the capabilities which are capable, which are having the basic infrastructure to make and manufacture any kind of the active pharmaceutical ingredients with having a capability of filing the DMF or drug master file to FDA. They can also apply for the investigational new drug applications. They can apply for the new drug applications. They can apply for the ANDA or abbreviated new drug applications with the FDA. But having said that, drug master file is not a regulatory mandate. It is just an ancillary process which happens simultaneously along with the new drug applications to the FDA, for which 2 to 3 weeks time frame has been given, and it's an online submission process. But if as a manufacturer, once submits the DMF plants need to maintain a highest quality standards of the manufacturing practices to ensure that the quality of the safety of the drug matches as per the FDA requirement to match the global quality standards. And therefore, it is obviously it is being believed that the quality of the DMF grade facility product is of the highest standard in terms of the overall superior safety and efficacy. So therefore, drug master file brings the credibility and confidence about usage of the product and the clinical superiority in terms of the efficacy and safety pertaining and passing on to our patients. It brings the alacrity and assurance of the high quality standards, matching the FDA standards. And from the manufacturer perspective, it carries a lot of responsibility and rheology. Why? Because if the new drug applications actually allows any manufacturer who is developing that particular product with a drug master file, if it allows the manufacturer to enter in any given geography or market and receiving the marketing authorizations to promote that particular product for a given time frame, it is a one-time process. But DMF filing and its due approval and accreditations, it is a yearly process, because once the DMF filing is being acknowledged by FDA, it has to be renewed on a yearly basis. So DMF filing is actually allows the manufacturers to stay in that market for year after year. And that is why the consistency of the quality assurance being maintained from the manufacturer point. So it's a responsibility. It carries a lot of investment. It carries a lot of patience and alacrity to maintain and do entire regulatory steps to be followed judiciously, so that this entire maintenance of the filing is being done over a period of time. And therefore, it brings a lot of economics pursuance for the manufacturer. The reason behind is that as it's a very complex process, multiple steps are being involved, and it is a little bit of time consuming also to file a DMF and getting an acknowledgement from the FDA. It requires a lot of upfront investments, and that upfront investments, when we get the DMF product, API product, it is actually at the discretions of the manufacturer to get that product and scaling down to the economics of the in a given geography, particularly pertaining to say that to the Indian economics, in the Indian pricing strategy, to bring that product so that our patients to a large sections of the society can afford that particular product, not only at the matching to the US FDA or any other developed countries pricing strategy to match over. So if we see, as per the June 2020 figure, as per the different countries globally, India always leads ahead of the other countries like China or even the United States in terms of the total number of DMF products being filed. It is only because of the generic domain of the Indian market scenario, that the generic driven strategy and the APIs are being maximally manufactured by the Indian manufacturers. And that is why it is always being estimated that the maximum number of filings are being done by the Indian manufacturers to the world. So therefore, coming to the DMF dapagliflozin, it is a very critical and sensitive aspects to be considered from a pharmacological perspective, because it supports the marketing authorization application, as I already told. It gives us that alacrity and confidence to be comparable to the global quality standards, and contains the certain vital informations about the active pharmaceutical ingredient, drug products, colorants, flavors, and other aspects of the product, which actually ultimately decides, and it ultimately becoming some of the critical factors so far the superior efficacy and the safety of the product is concerned. So as a whole, we can say that DMF approved dapagliflozin meets the intersections of the highest quality, safety, and affordability for our patient. So therefore, on a large scale, broadly, the implications of dapagliflozin with DMF API for Indian patients is a new paradigm. No doubt that it is an Indian pharma space. It is going to imply the best in the global quality at the Indian pricing available to our patients. DMFs is always unwelcome news, because especially with the newer novel new category of the products like dapagliflozin, which are being used to a broad sections of the patients, like in chronic disease like heart failure, diabetes, and many other expanding newer indications also for this particular class of product. And as a company, as a Mankind specialty, our commitment has been to bring the best of the world to our Indian patients, and our going ahead with our philosophy of serving life. It is our commitment to the healthcare providers, to our patients, that this is just a beginning. There is more to come. In fact, for next couple of months, we are having a huge pipeline to bring many more such products with the DMF approved API, which is going to be only possible with your support and the effort. And thank you so much for your encouragement and inspirations and patience listening. With this brief note, may I request Professor Dr. Bipin Kumar Sathi to kindly start with your presentations and the opening remarks. Thank you so much.
Thank you, Sandeep. I'll try to share slides. I think you need to give me permission to do that.
Yes, sir. Right.
Okay, let me see. Yes. So
yes,
there is a slight change in the program, wherein I am projecting the slides ahead of Professor Ganpati. I would be talking about some aspects of dapagliflozin which are known and some which are under active investigation, and how this drug has changed the way we look at not just diabetes, but other metabolic diseases, and specifically heart failure, liver dysfunction, and as you know, kidney disease. This is something which is a new terminology, which talks about the cardio, renal, and metabolic system, which are basically interrelated to each other. And we took at the acute or chronic perturbations in these and how might they influence the function of other. For instance, it has long been known that decreased pumping of blood from the heart to the kidneys results in regional azotemia. We also know that renal dysfunction changes the lipid metabolism, as also the filtration processes worsen the hypertension, loading the heart. We are also aware or beginning to understand how metabolic dysfunction like mere fat deposition in the liver can be linked to coronary artery heart disease, mortality, and also kidney disease. And it is now easy to at least conceptualize that problems in one organ can lead to the perpetuation of dysfunction of other organs by numerous pathways, the neurohormonal, the neuroendocrine, the immunological mechanisms. And this is where the focus of single drug or a group of drugs affecting positively this is going to improve. For example, if you improve the heart failure, the kidney function improves. If you improve the hepatic fat deposition, the cardiac mortality comes down. If you improve the kidney function, the heart function also improves. So these are all very much interconnected. It is known that the comorbidities in type 2 diabetic patients are many, but heart failure and CKD are the most common first comorbidities. And in this particular cartoon, you see that 60% of the first comorbidities in individuals who had no problems to begin with belong to CKD or heart failure. Myocardial infarction and stroke, which were highlighted in the previous decade or so, are not the major components, and together the atherosclerotic cardiovascular disease comprises about 40% of comorbidities, as against the 60% of comorbidities accounted for by CKD and heart failure. We had been aware of the impact of multifactorial intervention on the CV outcomes, and this particular cartoon shows you the data of patients enrolled in Steno study in terms of death or CV disease in people who received intensive treatment at various point frames. And you find that at 21-year follow-up also, this continues to be relevant, indicating that diabetic patients do not just require glycemic control, they also have to take care of smoking cessation, hypertension, dyslipidemia, and those things together will give you better outcomes than just glycemic control. What if a drug can address many of these factors in one go? That is interesting. Also, it has been quite clear from the Swedish registry that despite a significant improvement in the state of care compared to the controls in the community, type 2 diabetics continue to have higher rates of death from CVD, death from coronary artery heart disease, and hospitalization for CVD. There are other studies also which said that when you correct for all factors, the blood pressure, the smoking, the glycemia, the hypertension, the dyslipidemia, even then, almost all the factors, specifically the atherosclerotic cardiovascular disease, are similar to that of non-diabetics, but heart failure continues to be a leading cause of the differences in the mortality rates. So now we have, thankfully, drugs which are able to address two or more of these mechanisms. Of course, there are statins, there are the mineralocorticoid receptor antagonists, the ACE and ARBs, the GLP-1 agonists, which are able to address albuminuria, CV benefits, intraglomerular hypertension, reduction in MACE, but it is only in SGLT2 inhibitors that you find a greater coverage of this in reduction of heart failure, heart kidney endpoints, CV death, and in individuals with pre-existing coronary heart disease or atherosclerotic cardiovascular disease, the benefit in terms of MACE as well. No wonder then the guidelines have been quick to give suggestions about the usage of these agents irrespective and independent of baseline A1C or metformin usage. Some people have said, which of course is carrying things maybe too far, that in a person who is detected diabetic for the first time, you might instead or before administering metformin consider SGLT2 inhibitors or GLP-1 analogs. But suffice to say that if you have got heart failure or CKD or ASCVD or indicators of high risk in terms of people 55 years older with carotid or lower extremity artery stenosis of more than 50%, SGLT2 inhibitors can be considered as also GLP-1 analogs. So in these three categories, only in the first you have got GLP-1 analogs and SGLT2 inhibitors, whereas in the second and third categories, you have, of course, SGLT2 inhibitors figuring prominently. And there is a suggestion that one might give some prioritization to SGLT2 inhibitors with proven benefits in this population, be it heart failure or CKD. And you see that, therefore, the dapagliflozin comes very strongly in this area because it has shown its mettle in these areas. There are, of course, other areas which I'm not highlighting in terms of weight loss, in terms of glycemic control without hypoglycemia, where also SGLT2 inhibitors score very well given their oral route of administration. The cost considerations have been somewhat erased by the newer generic versions of gliflozins. The effects of these drugs on the cardio-renal metabolic systems can be in terms of immediate effects that you see, which are because of glucose excretions, natriuresis and diuresis, which leads to a decreased myocardial sodium content, decreased intraglomerular pressure, decreased LV stress, decreased afterload, decreased preload, improved hematocrit, and decreased inflammation and oxidative stress. There is some suggestion to say that in the kidney, the impact of the SGLT inhibitors is synergistic to the ACE inhibitors, and that may not be restricted only to the afferent arteriole. There could also be an efferent arterial constriction, so in the effect, so that you have got decreased glomerular filtration, you have got decreased interstitial fibrosis, you've got decreased tissue hypoxia, you've got preservation of the erythropoietin producing cells, modulation of renal hypoxia, stimulating the erythropoiesis, and this improved hematocrit is also one of the factors that is responsible for the long-term effect that you see in terms of decreased CV events, decreased kidney events, and of course you have got decreased blood pressure, HbA1c, etc., etc. Each trial that has been done with the SGLT inhibitors has added to the evidences around these arenas, And the cardiovascular outcome trials done by the dapagliflozin group had the highest number of patients. And what was more important here was that about 60% of people did not have established cardiovascular disease, and also the GFR in these patients was about 67. These people were not that unhealthy compared to, say, a DAPA, to the CANVAS program, wherein 33% or 34% people had this kind of subject population, and EMPA-REG wherein less than 1% as also what is CV. So these people were diabetics, all right, but they were not as sick. And also, they were older individuals who had men more than 55, women more than 60, with more than one risk factors like dyslipidemia, hypertension, or smoking. And if the person had established CVD, of course, these people were having age more than 40 years. But a large number of people belong to, a larger number of people belong to this category. And in this population also, you decrease the hospitalization of heart failure, though the MACE was not decreased. A, because the subject is relatively healthy. We have talked about the crosstalk between the kidney and the heart. These people had GFRs of more than 60, so they were less likely to have cardiovascular events. And though the numbers were less, they did not reach statistical significance, not surprising. So this led to a meta-analysis which talked about what happens to MACE if you have got established atherosclerotic cardiovascular disease. And they found that in the presence of established atherosclerotic cardiovascular disease, there is protection. If you look at the meta-analysis of these three trials, the EMPA, CANA, and the DAPA included, a sub-analysis of subgroup analysis of declared TIMI showing people who had ASCVD or myocardial infarction in the previous 2 years also had benefit, concurring with the possibility that pre-existing ASCVD leads to or is a prerequisite for decrease in MACE by the SGLT2 inhibitors. And both CANVAS and DECLARE, which had large number of patients declare more than the CANVAS, did not show this impact when there was no atherosclerotic cardiovascular disease. The renal endpoints, on the contrary, just like heart failure and unlike MACE, showed a 24% reduction. And this means that this impact is not dependent on atherosclerotic cardiovascular disease. As far as the HbA1c was concerned, this is something which has led to the suggestion by the guidelines that the drug should be given independent of HbA1c. You found the impact in HbA1cs as low as 4 versus as high as 12. So we don't want people to be at HbA1c of 12, but irrespective of the HbA1c, this benefit was there, and this was not mediated or modulated by glycemic control. If you look at the other study, this DAPA-CKD study, you find that in blue, dapagliflozin leads to a decrease in the GFR acutely, but after 12 months, this tends to equalize on account of greater decline in GFR of people who are receiving placebo. And by about 1.5 years, you find that dapagliflozin people are doing better than that of the placebo, irrespective of the CKD category they were in, whether it was stage 4 or stage 2 or 3. In this particular study also, death from any cause was lower. So not only in patients who were having DKD with proteinuria, not only there was a protection against the renal events, which all of you are aware of, but also it led to lower mortality. And it's of course a kindergarten stuff for you that the doubling of serum creatinine, need for renal replacement therapy, and death as also proteinuria were reduced, unlike that with GLP-1 analogs, which only have impact on proteinuria. Albuminuria, as I mentioned, was lower in the group with dapagliflozin, and this impact was seen more in individuals who were having diabetes. Mind you, this group study had also shown beneficial effect in people without type 2 diabetes, but the effect on proteinuria was greater in individuals who had diabetes. What are the new things? We know that heart failure is associated with diabetes. What we do not, many of us know, is that many patients with heart failure also develop diabetes. So this is a bidirectional process, much like sleep apnea and diabetes, obstructive sleep and diabetes. Similarly, CKD is also associated with metabolic syndrome, and type 2 diabetes mellitus is also associated with CKD. So this is also a bidirectional process. What happened to the individuals who were in the DAPA CKD and heart failure population who were not having diabetes? They had a 33% relative risk reduction for development of diabetes compared to that of placebo. So this is something important, that these drugs do not cause only a protection of the kidneys or of the heart, but also protect against the development of heart failure, of new onset diabetes. What about epicardial fat? Epicardial fat is higher in diabetics. Its thickness is a marker for visceral fat, and there are studies which show that the weight loss produced by dapagliflozin is there, and it is seen also in the epicardial fat. And that might contribute to decrease in atrial fibrillation or the sudden demise that happens in people with diabetes. So if you reduce that, you might improve the outcomes. What about the hepatic fat and NASH? There were some papers which had looked at this and talked about the effect of DAPA vis-a-vis sitagliptin and pioglitazone, other two non-hypoglycemic producing popular therapies for type 2 diabetes mellitus. And you find that decrease in the AST and also AST platelet ratio index, which they had calculated, was not seen with sitagliptin despite glycemic control, but was seen with pioglitazone, which is an established phenomenon after the PIVEN trial, as also in individuals who are on dapagliflozin. So early days, but some directionality. There was another paper which looked at the hepatic steatosis and fibrosis evaluated by transient elastography in patients with non-alcoholic fatty liver disease. And what did they show? They showed that this drug not only improves liver steatosis in parallel with decreased liver enzymes, but also attenuates liver fibrosis in patients with significant fibrosis. So what have we seen? The cardio-renal-metabolic symptoms are interrelated, and dysfunction of one organ or system can induce or contribute to dysfunction of others, and it can start from anywhere. It can start from liver, it can start from the heart, it can start from the kidney. Type 2 diabetes mellitus, cardiovascular disease, heart failure, and CKD are interrelated, and presence of diabetes is associated with cardiac or renal disease progression. The recent trials with SGLT inhibitors and GLP-1 analogs provide clarity for the choice of agents as a second-line therapy, specifically in individuals who've got ASCVD established or are at risk for ASCVD, as discussed earlier, heart failure, or CKD. When added to standard of care, DAPA showed beneficial results in the multiple risk population, in patients with heart failure with reduced ejection fraction, and CKD irrespective of presence or absence of diabetes, indicating that the benefit accrued was independent of, or at least not on account of, mere HbA1c lowering. What was important, that in subjects who did not have diabetes to begin with, addition of this agent reduced the progression to diabetes as well. The emerging impact of SGLT inhibitors and dapagliflozin in particular on epicardial fat and NAF failure are of great interest, and they open the vistas for future work in this direction. Thank you very much for your patient hearing. Over to you, Ganpati.
Yeah, sure.
Thanks, sir. Yeah. I request Dr. Ganpati. Yes, sir. Yes, it is coming.
It's coming, no?
Right, sir. Yes.
Thank you, Dr. Sandeep Mitra, for the invite. Thank you, Dr. Bipin Sethi. It was a great talk. We are actually talking on a new topic, dysglycemia-based chronic disease. How does the organ crosstalk to each other? So this is actually a position statement which came in the AAC, the first author being Jeffrey Mechanic. Now, why have they changed the nomenclature? So dysglycemia-based chronic disease as the insulin resistance, pre-diabetes, and the type 2 diabetes spectrum. See, what is important is diabetes exists as a continuum, and it is not just a distinct disease characterized by hyperglycemia. So in fact, even before the diabetes developed, you have the insulin resistance, and then the patients develop pre-diabetes, and then this is the evolution, what normally happens. Insulin resistance would have happened 10 years or 15 years before itself. And then you find that there is a slight increase in the blood glucose levels. And then you reach the diagnosis cutoff, fasting more than 126 and a 2-hour post-glucose challenge more than 200. And then we label them as type 2 diabetes. So this is how the evolution happens. And the key mechanistic drivers include the genome, the epigenome, and the environmental factors, a complex interaction of them, which actually leads to this. Now, why did they bring this? Even they have changed the nomenclature of obesity. So they have named it as ABCD, adiposity-based chronic disease, so that you know the bad effects of those increased adipose. Similarly, the slight increase in the glucose levels can also produce problems. And that's why the nomenclature is being changed to tell the impact of this. So what are the effects of dysglycemia on CVD? So you can see the coronary heart disease. There's an increased platelet reactivity, increased risk first myocardial infarction, decreased myocardial perfusion. So coming to the heart part, there's an increased extracellular volume, increased heart failure with preserved ejection fraction, increased impaired relaxation, increased microvascular disease, increased NT-proBNP cytokines, increased cardiac lipotoxicity, increased age-dependent remodeling, and decreased myocardial performance. And you can also see there's an increased prevalence of atrial fibrillation and increased hypoglycemia leading on to increased QTc. So coming to the interrelationship between adiposity and maladaptive changes in the heart and kidneys in the cardio-renal-metabolic syndrome. So you have this dysfunctional adipose tissue, and that actually causes a chronic low-grade inflammation. The good adipocytokine is reduced, that's the adiponectin, and the bad adipokines are increased. What it can do is it can lead to hyperfiltration, so which can lead to sodium retention, glomerular sclerosis, tubular interstitial fibrosis, proteinuria, decreased GFR. In addition, insulin resistance can lead to hyperuricemia, which can also lead to the hyperfiltration. It can lead to sympathetic activation, RAS activation, oxidative stress, inflammation, and all these things can also lead to endothelial dysfunction, oxidative stress, inflammation, reduced bioavailable nitric oxide, impaired relaxation. And as you know, endothelial dysfunction is happening everywhere, including the kidneys, and that's the reason you get the microalbuminuria. And also the dysfunctional, because there's a chronic low-grade inflammation, you have an impaired diastolic relaxation, leads to future loss of systolic function. So you can see the obesity, the visceral adiposity or the central obesity, insulin resistance leads to hypertension, metabolic dyslipidemia, proteinuria, and reduced kidney function. So this is what happens. Now, why this framework of DBCD? So the usual, what we see, the traditional chronic disease model focuses on tertiary prevention. We want primary prevention. So it compromises the effort to mitigate morbidity mortality, and the risk for acute and chronic diseases. So we require to optimize the care of patients with or at risk for type 2 diabetes. So this DBCT model addresses these challenges by positioning type 2 diabetes and pre-diabetes along a continuous spectrum. For everything we have now, I told for adiposity, similarly we have for Cushing's, you have a preclinical Cushing's, even before that. So, or maybe we have osteopenia for osteoporosis. So everything is happening even before. So that's what is happening, so that we prevent it, a primary prevention, something like that. So insulin resistance leading to pre-diabetes, leading to type 2 diabetes, to vascular complications. So this is what is happening. So maybe we must target from insulin resistance itself, so that you don't progress to pre-diabetes, or from pre-diabetes to type 2 diabetes. And if you have progressed to type 2 diabetes, see that you reduce the complication. So the DBCT encourages earliest intervention, focusing on structured lifestyle change. Now, what is the impetus for this new model? So pre-diabetes is not an entity in isolation, but rather as a necessary event along a spectrum with antecedent drivers and downstream consequence. Chronic endocrine disease models in obesity already exist, particularly incorporating early and pervasive structured lifestyle changes. And you require a heightened awareness and the need for a new type 2 diabetes care model that is actionable and results in earlier diagnosis and prevention tactics. So this is the following structure, the framework of this. Stage 1, insulin resistance. Stage 2, now you have some biochemical evidence that you have become pre-diabetes, a slight increase in the fasting plasma glucose, or you have IGT. And then the stage 3 is the classical type 2 diabetes, fasting more than 126 and 2 hours more than 200. And then stage 4 is the prevention of complications, vascular complications, or the micro and the macrovascular complications. Now coming to the insulin resistance at the intersection of adiposity-based chronic disease and dysglycemia-based chronic disease. So let us go to the dysglycemia-based chronic disease. Before that, ABCD. So obesity, what's the cause for that? Genetics, 40% contribution, environment, 60%, and of course, behavior. So you can see this is at risk. You are just eating a little bit more now. You're not yet become obese. Stage 2, increased, your weight is more now. There's an abnormal distribution, abdominal obesity, and abnormal function starts. So, and stage 3 is you have now reached the threshold for obesity. So anthropometric threshold, that is in the Indian context, more than 90 in males, abdominal circumference, and more than 80 in females. And the biochemical threshold, that is the BMI, more than 23 to 25, we call it as overweight, and more than 25, at least in the Asia Pacific, for obesity. And stage 4 is you develop the cardio-metabolic and biomechanical complications. So you get an osteoarthritis. The cardio-metabolic include increased glucose, dyslipidemia, hyperuricemia, hypertension, etc. So the same thing, if you have a more severe insulin resistance, you develop pre-diabetes, or then, which is a continuum, you progress to type 2 diabetes. And as you know, it can lead to micro and macrovascular complication. Now coming to the pre-diabetes problem. So as you know, around 24% of patients with diabetes and around 88.4% of patients with pre-diabetes are unaware of this condition. Now in India, we have around 77 million people with diabetes. Other 80 million people are having pre-diabetes and they are waiting to become diabetes. Approximately 70% of patients with pre-diabetes have a lifetime risk of converting to type 2 diabetes. In India, it's actually more. In fact, it's around 15 to 20% per year. From the Ramachandran study, it was around 15 to 18% per year. That was the rate of conversion. So primary prevention is a critical component of any comprehensive risk mitigation strategy. Interventions that improve insulin sensitivity can prevent type 2 diabetes in at-risk patients through weight loss, healthy eating patterns, increased physical activity, and various diabetes medications. Pre-diabetes is not just an isolated entity. They also are at increased risk. They have an increased CVD risk factors. A study from Huang et al. So they determined the relative risk in patients with pre-diabetes. 51% had dyslipidemia, 36% had hypertension, 25% were using tobacco, The 10-year cardiovascular event risk was 5.7%. And you can see for the composite CV risk was around 13 to 30% increased, for CST 10 to 20%, for stroke around 6 to 20%, and for all-cause mortality 13 to 32% increase. So pre-diabetes is not a separate entity. It's an independently associated with microvascular disease, which can, and also macrovascular, which can evolve into type 2 diabetes associated cardiovascular disease. So you can see the framing and heart study. Pre-diabetes predicts cardiovascular disease. This is the Kaplan-Meier plots of CVD-free survival by glycemic category. If you see here, the 4-year CHD event rates among women were around 30%, and more than a twofold elevated when you have a blood glucose between 110 to 125, and around threefold elevated in patients with diabetes. And this is in women, and the corresponding rates in men were around 2.9, 3, and 8.7%. So in men, especially when you become diabetes, the risk increases logarithmically. And not only that, you have an increased mortality risk even for IFG. We used to always tell, no, only the postprandial glucose is, has an increased risk. But then you find that even IFG also carries an increased risk. Now, if you see that, what about the heart involvement in pre-diabetic, especially IFG with the lifetime risk of incident heart failure? So you can see the risk of heart failure is increased in people with a fasting plasma glucose as low as 100 milligram per deciliter. So the orange one is 100 to 125, and diabetes is the red one. So slightly above the normalcy, you can see there's an increased risk, and diabetes, of course, significant increase. So we now have told about that it is an evolution and it's a spectrum. So starting with insulin resistance, leading to pre-diabetes and then to diabetes. Now, if we intervene them, will we mitigate this risk? So there is a progression of type 2 diabetes related complications without intervention. Second, there is a reduction of this cardiometabolic risk with lifestyle and weight loss intervention. Third, there are decreased healthcare expenditures with intervention. So with this emerging evidence base affirming benefits of early intervention, the next question is, why are these maneuvers not more aggressively applied well before a patient is diagnosed with type 2 diabetes? So this is how the system works. So you can see insulin resistance, you begin with insulin resistance, that's a molecular part. This is primordial and primary prevention. If you do that, you are reducing the risk to stage 2 to 4. You are reducing it. How do you do that? Eat healthily, exercise well, see that the patients, I always tell you, primordial include prevention of gestational diabetes so that the offsprings are not at risk for developing diabetes in future. So prevent gestational diabetes. And then the second is the biochemical cardiometabolic risk, primary and secondary prevention. So this reduces the risk to overt type 2 diabetes and also reduces the complications in future. And stage 3, the biochemical disease, the secondary. So here what happens is we can only prevent the secondary and the tertiary thing. So you're preventing the complications and maybe the mortality. And finally, with complications, the stage 4. So 4A is mild complication, 4B moderate, and 4C is severe. We reduce this progression. That's what we are doing. So early dysglycemic stage can be used as the basis or low or high risk for chronic CVD along a cardiometabolic spectrum. So primordial prevention to decrease diabetic risk factors in the general population. So what do we want to achieve in the primary? To decrease the conversion from pre-diabetes to diabetes. To detect secondary, to detect disease and decrease morbidity in patients with early asymptomatic type 2 diabetes. The tertiary is to decrease progression of type 2 diabetes related complications. And the quaternary is decrease overmanagement, medical any patient along the spectrum. Each dysglycemia stage can be viewed as the basis or low or high risk or for chronic cardiovascular disease along a cardiometabolic spectrum. Coming to stage 1, so what we can do? How can we do? What are the pragmatic relevance and actions? Epigenetic risks for the ABCD, adiposity-based chronic disease. Maybe we have to look for some investigational molecular markers family history. If you have a family history, if there is a genetic risk, maybe we can look into that. Base for the cardiometabolic dysglycemic risk, basal hyperinsulinemia, if it is there, abnormal adiposity, you require policy, laws, and education for a healthy built environment. Like the Supreme Court has already told, no smoking in 200 meters. Similarly, we must tell the junk food should not be consumed. There should not be any provision for this in the schools. They must mandatorily have exercise every day, once at least for 60 minutes. Lifestyle changes should be encouraged, cardiometabolic health. Now coming to stage 2, which is a biochemical cardiometabolic risk of prediabetes. So what do you do here? You have to screen, manage other metabolic syndrome components, hypertension, maybe hyperuricemia, increased TG, decreased HDL. You will have to tackle that. GDM, if the patient has GDM, give intensive lifestyle intervention. PCOS, tell them once again intensive lifestyle changes, or maybe we may use metformin at that stage. And in fact, by this, we are accelerating the cardiometabolic risk. PCOS at increased risk for developing diabetes and cardiovascular disease also in future. Suppose you have IFG, IGT, and increased A1C, intensive lifestyle, and pharmacological therapy if you don't achieve them with the ILI. And also look into the cardiometabolic risk factors and treat accordingly. And the stage 3 is where we are actually playing a role. Like we start them on pharmacological therapy. We tell lifestyle, intensive lifestyle interventions, diet and exercise, and the cardiometabolic disease risks are also being managed. Stage 4 is prevention of the vascular complications, or you already have a complication, try to reduce it. So here, structure lifestyle changes with increasing medication and other procedures like renal and type 2 diabetes nutritional recommendations for patients receiving hemodialysis. Suppose he's obese, is developed diabetes, short duration of diabetes. I think very much obese can suggest bariatric surgery, and comprehensive cardiac rehabilitation after CABG that also includes nutritional and behavioral counseling. So this CRM systems are interrelated. That is the cardio-renal-metabolic system, the organ crosstalk hypothesis. Heart is the most metabolically demanding organ, which is susceptible to changes in volume and metabolism, even a slight increase in glucose, the pre-diabetes stage itself, or insulin resistant stage. So that's the reason you find that macrovascular complications happen even before you become diabetic. So it's there even long before. So how do you, and then you can also see the kidneys also play a key role in glucose and volume homeostasis and blood pressure regulation, and the regulation of energy metabolism by liver, pancreas, and fat is essential for healthy function of organs, especially the kidneys and the heart. Metabolic dysfunction adds to the cardiac and the renal burden. So it can affect cardiac and renal disease progression and outcome. So if you have hyperglycemia, dyslipidemia, increased insulin resistance, altered hormonal milieu, like you have a PCOS type of patient, increased bad adipokines, can lead to fluid retention because it's a selective insulin resistance, increased sodium reabsorption, albuminuria can happen, declining kidney functions, hyperuricemia can happen. Similarly, because of this, can lead to heart failure, vascular dysfunction, and atherosclerosis. So insulin acting via the MAP kinase and stimulates atherosclerosis. Cardiac dysfunction adds to the renal and metabolic burden. So cardiac dysfunction, as you know, can affect the renal and metabolic disease progression and outcome. So if you have hypoperfusion, you have a volume overload, increased arterial resistance, change in substrate utilization, autonomic dysfunction, all these things can lead to increased insulin resistance, increased free fatty acid, and dyslipidemia. In fact, when you have severe heart failure, your glucose control goes haywire. And in fact, that's because of the increased catecholamine levels. So that's the reason when you give a cardiac LVAD assist device, the requirement of insulin suddenly comes down and the blood glucose becomes easily controlled. It can also lead to hypertension, albuminuria, and worsening or declining kidney function. Vice versa also takes place. Renal dysfunction can also affect cardiac and metabolic disease progression outcome. As you know, with the renal involvement, there's an activation of the RAS and the sympathetic nervous system, more sodium and fluid retention, hypertension, arterial calcification, oxidative stress, also can lead to insulin resistance, abnormal glucose levels, and in the kidney and the heart, it can lead to ventricular hypertrophy, heart failure, vascular dysfunction, and atherosclerosis. So coming to the comprehensive approach to cardiovascular, renal, metabolic disease risk reduction in type 2 diabetes, primary and secondary prevention. So you have primary prevention include starting with the beginning itself. So you have weight management, exercise, blood pressure control, lipid control, glucose control from the beginning, obesity control, by which you can actually see that you don't become obese. If you have become obese, see that you don't develop abnormal lipid deposition in the abdomen, because that's a bad fat. So this is primary prevention, and also prevention of gestational diabetes. If I've already developed it, then we try to prevent it, and that becomes a secondary. Usage of appropriate drugs, use metformin, use an SGLT2 inhibitors, so use anti-hyperglycemic agents. If you have dyslipidemia, with lifestyle, if you're not able to change it, then maybe you'll have to use a statin for hypertension, ACE, ARBs. You can use stop smoking, alcohol in moderation. So by this, we actually prevent this cardiovascular disease, renal disease, and a metabolic disease continuum. So in conclusion, dysglycemia can be viewed as abnormality in glycemic state associated with disease or disease potential. Dysglycemia-based chronic disease paradigm places insulin resistance, pre-diabetes, metabolic syndrome, type 2 diabetes, and CVD within a single chronic disease based on scientific data and a current understanding of common pathophysiologic mechanisms. The DBCD model positions type 2 diabetes and pre-diabetes along a continuous spectrum from insulin resistance to pre-diabetes to type 2 diabetes to vascular complication. And each dysglycemia stage can be viewed as a basis, low or high risk for chronic CVD along a cardiometabolic spectrum. Recognizing and managing pre-diabetes is a necessary component for a type 2 diabetes care plan. Thank you for patient hearing.
Thank you, sir. Thank you so much. We have one question in the chat box. So request Dr. Ganpati and Dr. Sethi to kindly put your comments. Yeah, it is saying dapagliflozin is advised to prevent kidney disease progression, and it's not indicated to give in patients with GFR less than 45. So in such cases, if the patients are having nephropathy, what is the ideal drug of choice?
I think the question is very interesting. One needs to look at two aspects. One is the renal protection, for which you can give this drug up to GFR of 30. Some people say even 25, but our regulators have approved it up to 30. In this setting, you are using the molecule for its cardio-renal benefits. The glycemic control is not good, and you would require GLP-1 analogs or D4 inhibitors or anything else. For a glycemic control standpoint, yes, the drug should be used when the GFR is permitting its action. Higher the GFR, greater is the HbA1c lowering. The closer it is to 45, the lower is the HbA1c lowering, and between 30 to 45, hardly 0.1 to 0.3. So there are two issues. For cardio and renal protection, this is not, GFR is not a barrier. You can use it for heart failure and CKD up to GFR 30. It highlights two things. A, the benefits are independent of and not accrued because of glycemic control. And glycemic control is also important. For that, you require something else. You can choose from any of the non-hypoglycemia producing agents if you wish to. And if GFR permits, you can use certainly metformin in the half the dosage that you have set GFR of 45 and 30. But you have to distinguish between usage of GLP-1, the SGLT2 inhibitors for glycemic control versus for organ protection. I think that is a distinction, and thanks for pointing that out. Ganpati, you want to say something?
Nothing, sir. You actually answered. See, up to the level of GFR of 45, the efficacy of DAPA or whatever for SGLT2 is very good. Below that, the A1C reduction is just 0.4. So then it's not, we are using it not for its glycemic efficacy, but as Dr. Bipin Sethi sir told, it's for the other reasons. You can use up to 30, that's DCGI approval, but then there are studies where they used it up to even 25. So you can actually use up to that also. And not only in diabetic, non-diabetic also you can actually use it now.
Right, sir. There is another question, if you can kindly comment, whether in Asian patients, do you feel that the SGLT2 inhibitor has got a better effect?
I think there are some studies showing that thing, but then the numbers are too small to say. Sir, what is your comment?
Well, whether it's AGIs or DPP4s or GLP-1 or SGLT2s, I think there, with one reason or the other, people tend to project studies. But I think there is no need to project the Asian angle. There's enough reason now to use these drugs. And as my professor used to ask previously, Dr. Shamsundar, show me a patient who does not require statin. Now the slogan is, show me a patient who does not require SGLT2 inhibitors. So much so that you are now looking at reasons for not giving this molecule. The person who raised the first question obviously has also pointed out that even in the categories where you would not use it for glycemic control, you would still be using for something else. So there are very few reasons for not using this particular drug. So I think the modern slogan is, show us a patient who does not require statins, show us a patient of type 2 diabetes who does not require SGLT2 inhibitors. You can have cost considerations, you can have so many things, but there are many virtues in these molecules. Apart from this narrow cardio-renal protection, they offer euglycemia without the fear of hypoglycemia. And I keep repeating this again and again. We have a unique disease which we diagnose as HbA1c 6.5. And what is the target? 7. Wonderful. Why? Because we are afraid of hypoglycemia. The moment you take away hypoglycemia, whether you use SGLT2s, DPP4s, AGIs, metformin, glitazones, you can lower HbA1c to 5.7 or low. So these drugs help you reach the targets and erase the bad metabolic memory and produce good results and outcomes. I think we have just seen the beginning of a revolution for better management sans the fear of hypoglycemia or weight gain. So there are other indications, of course, in specific situations, these drugs have got no equal.
Right, sir. There is another question where you need your comment about the combinations. How do you look at the usability of these combinations in the Indian patients? Any specific category of the patients who might get benefited with the fixed dose combinations of the DAPA plus metformin? On the similar line, we received another question. If you can, sir, kindly comment about combinations of metformin, SGLT2, where to use them, especially those patients who are already on multiple therapies.
Ganpati, you want to take that first?
You take, sir. I'll add on anything.
Yeah. So the issues are again two. We have again compartmentalized people for usage of this drug irrespective of glycemic targets and HbA1c, wherein it doesn't matter whether you use it, you have to add it on to, or you may replace drugs like sulfonylurea or something else. In that category, the indication is anyway clear. What the question is about the usage of these agents for glycemic control. Yes, that is important and relevant. That's why we are treating diabetes. If your HbA1c can be controlled with single agent, barring a single study verified with DPP4 inhibitors, there is still not much evidence that you should use 2 drugs to begin with, though it sounds to reason, but adds to cost of therapy. So there is no study with SGLT2 inhibitors, and the verified authors also were very careful to point out that this observation can also be extended to other therapies which can produce a better control in the beginning and is not limited to or the DPP4 inhibitors. So if you are going by the ground rules, if you are not able to achieve or you think you cannot achieve good glycemic control with single agent, you can confidently add these agents in obese people or in people who are, you are having some additional benefits in terms of D4 inhibitors over D4 inhibitors in terms of blood pressure and some other issues for those who are not having clear-cut indications. So instead of D4 inhibitors, you might use SGLT2 inhibitors because you have slightly better or similar HbA1c lowering if your renal function is appropriate and normal. So the answer to your question is, you can use this combination to improve the patient compliance to reach the target when you are reasonably certain that single drug is not able to do it. And the aggression with which you approach the targets will definitely be increased if you have the confidence that the patient is not going to have hypoglycemia. But one must also add a note of caution here that one must tell these people about the risk of genitourinary mycosis, which many people can get, and also not use them in grossly insulinopenic people. It is very, very exciting to say higher the HbA1c, better the efficacy, but higher the HbA1c, greater the insulinopenia, greater the likelihood of giving it to a person who might actually be requiring insulin. And thirdly, if you feel that HbA1c cannot be lowered by 2 drugs, you might add a third drug in a DP4 inhibitor, which will also lower the incidence of genital mycosis, as also add to the efficacy across all the GFRs, which is a rule for almost all the DP4 inhibitors. So depending on HbA1c, the AS guidelines are very clear about that. If HbA1c is 6.5 to 7.5, 1 drug, HbA1c 7.5 to 9, 2 drugs, more than 9 without symptoms, 3 drugs. So I think you can stratify this, and if you are using non-hypoglycemic producing therapies, then you can be metformin, SGLT2 inhibitors, and D4 inhibitors in this order, or if you are wanting, you could use it metformin, D4 inhibitors, and SGLT2 inhibitor, but I prefer the metformin, SGLT2 inhibitor, and D4 inhibitor, that kind of a sequential addition. Over to you, Ganpatiji.
Yeah, I think I concur with your suggestions. There has been instances where I've actually used this triple drug from the beginning itself. So there are some people who have, say, HbA1c of around 9%, where I have actually started this with the blood glucose of, say, a fasting of 220 and a postprandial of around 350, where I use this drug with the caveat that, yes, see, you have to be careful about that genital mycotic infection, which you told that you have to be careful. So in my prescription, I always write that genital hygiene to be maintained. If you continue to get that candid cream, if you still don't, then take fluconazole daily 1 tablet for 3-4 days, and then weekly once for 4 weeks, so that this is taken care of. More so when you're using it when the blood glucose is high, because they are already at risk for developing genital mycotic infection, and you give with this, it will only worsen that. So then I'm a little bit cautious, tell them about these things and start. So triple drug combination also have been used from the beginning also.
Right, sir. I think we received just another question with reference to the guidelines directed therapy. How do you would like to place dapagliflozin in the I think diabetes and metabolic continuum or the journey of the patients?
I think if you have studies on obesity with SGLT2 and on pre-diabetes, which are actually going on, perhaps then we may probably start writing this from there itself, because it's a continuum. We have to reduce the insulin resistance, that leading on to dysglycemia, that is pre-diabetes, and then finally prevent. So if you have more evidences, probably we will start writing this then itself. And of course, the guidelines clearly say that you can start it in the beginning, more so where you should write it mandatorily if you have an ASCVD risk. At that time, you actually start along with metformin, you can actually start it from the beginning itself. But then pre-diabetes, or for that matter in the increased insulin resistance part, a little bit more evidence, trials, and then probably we could start. Sir, your comments.
Yeah, I think it looks exciting, but at least in the arena of heart failure and CKD, without diabetes, you can have the added confidence that you might prevent the onset, or at least delay the onset of type 2 diabetes in these individuals, apart from giving them the benefit of decreased cardiovascular mortality, decreased renal events, as also decreased admissions for hospital for heart failure. There's also emergency room visits. So there is some evidence building up, but it takes a lot of time for evidence to build up. I keep looking at, I don't know whether Ganpati, you looked at it. What was the weight loss in CKD patients without heart failure, without diabetes, heart failure without diabetes? There might have been some, but I think the weight loss could have been possibly modest. So it depends upon how much was the weight loss, and we'll get some signal, and I'm sure in some time to come, you will get some publications out of it, but that data was not highlighted in the primary publication about what happened to the weight in the non-diabetic individuals, because many people keep asking this question, can I use it as a weight loss drug, much like GLP-1 analogs? But I think that is where the GLP-1 analogs have got more evidence compared to SGLT inhibitors.
Right, sir. Sir, your comment about the combination, I think already you commented on this, SGLT2 inhibitors plus gliptin in the therapy continuum for diabetic patients, primarily because this question is on vildagliptin combinations with SGLT2.
I think this has been told very clearly by Dr. Ganpati that we are looking at glycemic control, and if it is not possible with 2 drugs, we can add a 3rd drug. And I also highlighted that there is sufficient evidence that not on account of glycemic control, but on account of some unique properties of D4 inhibitor, the incidence of genital mycosis is definitely decreased in a combination. So you might, after metformin failure, if your HbA1c is about 8, more than 8, add these 2 drugs together so that you can have a better glycemic control. Whether you want to give it as a 1+2 or 3 or 1+1+1 depends on whether you like FDCs or you are liking the molecule. But the concept is very clear that you have to, I can't use the word hit, we have to act early, we have to act right, and we have to act fast, and we have to act with drugs that do not produce hypoglycemia, because the confidence with which we chase the target comes down very badly if we are having a sulfonylurea or even for that matter meglitinide in place, because at the moment the patient feels slightly jittery, you become even more jittery and you stop chasing the target. So this fear is not there. So you can have a control without any concerns about issues of at least hypoglycemia with these 3 agents. So that is what can drive this in individuals whose HbA1cs are say 9 without any symptoms. All 3 drugs can be given together, or if somebody is on metformin already and HbA1c is more than 8, I think all 3 drugs can be given together, provided it's 8 to 8.5 and not beyond that. I think people would require these 3 agents with basal insulin.
Right, sir. And I think another question is that though the data is available in the non-diabetic individuals or in heart failure, what is your real-life clinical experience about dapagliflozin usage in this subset of patients?
I think you're going to cardiologist to speak on that.
Correct, yes.
We can anecdotally say that I gave it to my uncle, my auntie, and this and that. But that is 1 or 2 cases. And whenever the uncle and auntie receive, they're very happy because they've been treated by the nephew. They'll say, I felt very better. I am feeling very good. That doesn't mean anything. So I think cardiologists use it, but this question is very relevant. While they are very eager to give it in the diabetic subset, whether they have this disease or not, and sometimes they admonishingly tell us that stop sulfonylureas, stop insulin irrespective of 100 units per day, they have not adapted to use these drugs in non-diabetic kidney disease for that matter, and also for heart failure. So I think we need to take their opinion, but it's very bad to be judgmental in the absence of an expert from that.
Right, sir. Yeah, fine, sir. That is all. We are through with the questions. Actually, any final comments and the take-home message for our audience from your end, sir?
Well, I think talking about dapagliflozin nowadays is like repeating the Ramayana. You know the story very well. Same Rama, same Sita, same Ravana. And every time it becomes very difficult to add newer things. But I must congratulate the organizers for having put a new flavor to this by adopting the position statement or the document from the ACE, which looks at the continuum. We used to talk about common soil hypothesis, at least while it was trying to link diabetes and hypertension together, insulin resistance, cardiovascular disease. They have carried it much, much beyond that, from what initiates, what perpetuates, what are the clinical or biochemical phenomena, and how are diseases there. And then that puts a lot of impetus. You know, and Ganpati also highlighted that we are very good, hopefully, at treating symptomatic disease. Asymptomatic disease, somewhat okay. Pre-diabetes is largely left to gods or dogs. And regarding the obesity, the lesser the said, the better it is. But this statement has really put emphasis on where all we can intervene and where it is most relevant. And Ganpati was very clear in pointing out that it is, if we have to attack the root cause, we have to address obesity, we have to address our food habits, our lifestyles. And whatever we are doing now is just like a firefighting operations, much like the politically speaking, the withdrawal or repealing of certain laws after certain things have happened. We are acting at a very late stage of the disease. And also, in this context, I would like to again state in one line that do not delay the use of SGLT2 inhibitors till the person has heart failure or CKD with proteinuria or is at, say, having ACVD. It is more at the level of prevention, more at the level of aggressive target chasing with additional benefits of weight loss and blood pressure. So do not restrict them or do not misinterpret or read for your own convenience the guidelines. They are indicated everywhere, and you must use them to give a good benefit. We have used metformin in the past. We have used D4 inhibitors in the past, and there is no reason not to adopt this with additional fringe benefits in terms of SGLT inhibition.
Yeah, I think I concur with Dr. Bipin Sethi. Start it at the earliest so that they get the benefit, not necessarily for glycemia. So you don't use it for glycemia benefit only. It's also giving you cardio, renal, and now also maybe liver benefits, eye benefits. In fact, I keep telling that there are some studies telling that reduction in cancer, though initially DAPA, before it came, it was halted because they found there's an increased risk of cancer. But then now they're working on that and telling it's acting on the mTOR pathway and is reducing the cancer. A recent article on retinopathy telling that it's beneficial there also, reduces at least there's a I think a few case reports telling that reduces hyponatremia also. So much benefits are coming in this. Of course, we must know the side effect also, the genital myocardial infection. So this part you must tell, and where you should not use it. So somebody is having a prostate enlargement and having a problem. So then recurrent UTI, avoid them when there is no reason and you found this is the only thing. So you must know where not to use it also, but otherwise a great drug for use in diabetes.
Right, sir. Thank you so much, sir. Thank you very much, Professor Dr. Bipin Sethi, sir, Dr. Ganpati Manpal, sir, for enlightening us. And this subject, which we actually kind of chosen, particularly this dysglycemia-based chronic disease model, which we found very, very kind of, fascinating in terms of the disease continuum to discuss and where to actually kind of position and place the current therapeutic solutions, from the clinician's perspective. And thank you, Dr. Bipin Sethi, sir, for enlightening the clinical usage and the utility of the dapagliflozin, going ahead with the emerging evidences and exploring the newer positions and the indications, as you commented that in the entire metabolic this array of the disease, there are many other areas like non-alcoholic fatty liver disease also we are having some kind of a data and which is also emerging. Obesity also some studies are kind of going on. So I think going ahead, this class of molecule is going to have a kind of a great future. In fact, once we witnessed in one of the sessions in the last ESD Congress that 100 years of insulin we are celebrating, what could be the another molecule in the next 100 years? So there was a debate sessions with the close unity of the discussions with SGLT2 inhibitors in that context. So thank you so much, sir, for enlightening and giving such a fascinating insights, and hope all the attendees in our audience must have thoroughly enjoyed these scientific discussions, good participations of some of the very relevant, important questions. And with this, we conclude this session. Thank you so much. Thanks each one of you for joining and participation. And our continuity and our commitment of taking ahead different scientific forums will continue to remain under your support and the guidance. Thank you so much. Stay safe. Good night. Thank you.
Thank you. Thank you. Bye-bye.
Thank you so much. Bye.
Bye.
Thank you.
Bye. Thank you.